I'll tell you, we tend to go a little long, so if you need to go before we finish, just know that, again, we are recording the session, and we do send a link with a thank you for attending at the conclusion of the seminar, probably sometime on Monday or Tuesday, but know that if you have to go, it's okay. You can always kind of revisit this. I'm going to go over a couple of housekeeping items before we get into the training session. First things first, I already mentioned that the webinar is being recorded. And for those of you that aren't here live, the reason to come to the webinar while it's being recorded is that you do have the option of answering questions, which leads me to bullet 2. Questions are vital to any good webinar or seminar, so I encourage participation. And how we do participation or provide you access or participate in the webinar is through chat in your dashboard. There's 2 ways to do it. The first way is through the chat box. So I'll be monitoring the chat box from time to time, and if I see a question, I will pause, and depending on the nature of the question, I'll either tackle it right then and there, or we'll save the questions to the end. The other way to do to interact is there's actually a questions option in your control panel, or your panel, and you can type there, and again, I will be monitoring that throughout the seminar. There are 2 documents available today. There's the presentation that you're going to be looking at with me as I narrate it. So that is, you do have that PDF document of the information. And there's another document that I have in the handout section. It's the test. And that leads me to bullet 3. There is 1 hour of CE credit available, assuming that you have completed both requirements. One requirement is that you either attend the webinar or view the video after the webinar has been recorded. And then the second requirement is that you take a test. And the test is pretty straightforward. It's 9 questions. And you guys may know that in the course of getting CE credit, you've probably had to take these tests before. We tend to make them fairly easy, but they are targeted towards the content that we provide. And the CE folks require that we kind of prove that you are better off after the webinar or seminar than when you started. Okay, so with that being said, let's talk about the major points that we're going to be covering today. Is bruxism or a symptom of another problem? So we'll spend a little bit of time and I'll explain why that's related to appliances and review of appliances. Are you going to be managing a patient's airway? That's a loaded question. It sounds simple, but it's not. There's a lot to in your practice if you're going to take on sleep apnea or not. If depending on the answer to that question actually has implications to what you do about bruxism. So that's why we're going to spend a little bit of time talking about that. There is then we're going to the bulk of today's webinar is going to be on number 3, bruxism guards and sleep apnea appliances. And that is going to be a review of features and benefits of a variety of appliances in an objective fashion. So what I mean by objective fashion is in dentistry, there's a lot of education available, as we all know. In fact, you're attending an educational opportunity as we speak. And so much of the education that is out there is delivered via companies that have a stake in the thing that they're talking about. And so DDME and Whipmix, who are co-partnering in offering these products related to sleep apnea, have decided to put on these webinars. And you should know that we do not have a sleep apnea appliance available. We do have a bruxism guard available, and I will talk about that. And I will clearly tell you I am in sales mode. And then that way you know that the information I'm delivering to you in sales mode, I have a stake in. If we're not in that mode, I don't. So the reason that I kind of emphasize that is when I'm talking about sleep apnea appliances, I have no stake in what appliance you select. So there's the benefit of it being completely objective. And we are going to talk a little bit about the Bruxism monitor, sleep apnea monitor that Whitmick sells, and that has a stake in all aspects of appliance therapy. So that's a kind of another item that we have a stake in, and I will tell you, obviously, when we're talking about that that's the case. And then finally, I do like to talk about educational opportunities. I probably should have added S6 here, but I do have some recommendations on educational opportunities that we'll talk about. And then today we have a unique opportunity. DDME develops dental products, and we have a couple of products coming out. And if you would like to participate in a question and answer session, yeah, I'm going to send out a couple, I'll talk about some of the things that we're thinking about, and then if you want to participate and you want to reply back or answer some of the questions that I would like to ask, stay afterwards if you have the time. The reason being is we're going to do some market research. We're developing a couple of exciting new products, and I can't wait to talk to you about them. And in the course of developing any new product, it's always prudent to get market feedback in the process of development. And so we're going to be doing that at the end. If you have a few extra minutes, we'd appreciate it. If not, obviously, you're free to go on your way. Okay. All right. First things first. What are we treating? So when we're talking about appliances, I think, my personal opinion is there's a couple of sets of influences that guide appliance selection behavior. And some of them are clinical, some of them are financial, some of them are what's available to you. And then in my experience, the most powerful influence is what have you had success with. And so when we are talking about appliances, I believe not enough time is spent on, okay, what am I treating? And it sounds silly, but you may be treating things that you're completely unaware of. And when I say treating, having an impact on, okay? And what I mean by that is if you're have a patient in front of you that has, let's say, some anterior wear, and you want to prevent further damage to the front teeth, and you put in some type of guard. Okay, now what if that same patient snores and you might find out later that they have sleep apnea? Are you still going to be treating bruxism? If you don't know what their cause of the bruxism is and you protect the teeth or try to relax the muscles while they sleep, or what may be your strategy, maybe you're dealing with a pain patient or what have you, when you do something, you may have a profound effect on the cause of the very thing that you're treating, and you may be unaware of it. So that's why I like to spend a little bit of time on appliance selection. So the 4 bullets are bruxism, damaged teeth, jaw pain, TMJD, ad infinitum. Snoring. Probably, I would guess, the number one airway-related issue that people are willing to talk about is snoring. So if somebody comes to you and says, oh, I saw a news story that snoring is something that dentists can help you with, you should know that, and I think most people on this call, I saw the list of attendees, most people on the webinar here know that snoring and sleep apnea are intertwined. They're not always intertwined, but usually they are, and snoring's on a point in the airway issue spectrum or continuum that sleep apnea is. So depending on where that patient is in the continuum of airway issues will dictate what, if they truly are just a snoring patient or if they're snoring and sleep apnea. Some people have sleep apnea and don't snore, okay? And then to me, the single most important airway issue for dentists is upper airway resistance, flow limitation, and respiratory effort related arousals, or RERAS. And the reason that I believe that's very important for dentists to sort out if they're going to manage a patient's airway is it's been our experience that those, that fourth bullet is the number one trigger for clenching and grinding. So even if you say, I'm not going to tackle the airway, I'm going to refer those patients to somebody who's better suited or whatever the reason for referring them out, know that when you're looking at somebody that has a complaint of bruxism, it could be that you're actually looking at an upper airway patient. Okay. Another really important issue, especially I think this is more for the sleep apnea, is what's your budget? What's your socioeconomic geographical location? Are you in Beverly Hills, or are you in some other town that doesn't maybe have the same level of status? And so that plays a role. The other item that I find has a profound impact on appliance selection is the dental lab that you use. What do they offer? Do they even offer a sleep apnea appliance? Many don't. So, when you call a lab and you say, listen, I'm thinking about getting into sleep apnea or treating patients with an oral appliance that have been diagnosed with sleep apnea, what sleep apnea appliances do you fabricate? And they might say, we don't do that, or they're going to give you probably 2 or 3 appliances that they make. Okay, so the lab that you use also has an important role. I don't want to say to beat a dead horse, but just to emphasize the importance in appliance selection for those dentists that opt to not tackle the airway but want to kind of stay firmly in dentistry in the sense that I'm going to just manage bruxism and whatever your strategy for bruxism is. And when I say bruxism, that's a very broad term. So let me kind of just step back for a second. And when I talk about bruxism, there's a bucket. Bruxism is a bucket. And in that bucket, there's clenching and grinding. There's parafunctional EMG activity. Okay, so when we get down to the nitty-gritty of bruxism, now that we can measure it, we can sort the type of bruxism into different categories. Okay, and so that when we talk about bruxism and the fact that we can measure it, because we can measure it on a timeline with some other parameters, the airway parameters, we can kind of triage, okay, is this truly a bruxer, or is this somebody that has an airway issue? And, at the end of their airway issue, do they clench and grind? So as you're sorting out what type of patient you're treating, if you decide to take a measurement on your patient, you'll get a lot more information and be able to make a more informed decision on what appliance is most appropriate. The chart that you're looking at, I'm not going to spend a lot of time on it. It just emphasizes the fact that if you're a dentist and you just manage, well, I shouldn't say just manage, but you've made a decision not to manage patients' airways, but rather just help them with damaged teeth, jaw pain, TMJD, or what have you. And if you suspect that the patient has sleep apnea, you refer them out. If that's you, on this chart, you should know that even the patients you decide to keep, okay, so it's not obvious. So it's not like somebody like you don't have a patient like me who's 51, 220 pounds, 6 foot, tired, snores a little bit. Okay, that patient probably has sleep apnea, and if a person comes to you and says, geez, I'm a little tired during the day and my teeth are chipped, what are you going to do with that patient? Okay. When you decide to protect their teeth, know that on this chart, when you protect their teeth with some type of bruxism guard, it has an effect on the airway. Sometimes positive, but most of the time negative. Okay, so it's probably 2/3 negative, 1/3 positive. So not that I am discouraging bruxism guards, because that would be silly. I'm just saying, know that those guards have an impact on the airway. Okay, and a lot of times it's not good. Okay. All right, so let's talk about bruxism for a while. So within bruxism, there's a number of types of damage that can occur. We all know this isn't new groundbreaking information, but there's chipped and fractures, there's abfractions, and then there's wear. Okay, so there's when you're dealing with somebody with bruxism, a lot of times you don't think about wear, because wear is a lot of times pressure and esophageal reflux acid combining to wear out the enamel on the posterior teeth. And over time, you can see what the effects are. Abfractions are thought to be from consistent pressure over time, and wherever that force is being borne on the top of the root, that section tends to wear out due to the pressure over time. And then there's chips and cracks, and those are just, those are pretty easy to figure out what that's from. So that's from clenching and grinding, and where the teeth come together, there's malocclusion, or there's no centric relation, or what, for a variety of reasons, the enamel is getting chipped and cracked as a result of pressures from, likely from bruxism. Okay? So in all three of these cases that are 100% dental, know that when you're selecting whatever your strategy is on patients that have these conditions, when you do whatever it is that you do, just in the back of your mind, just know that if there is an airway issue, whatever you do affects that issue. Okay. I wanted to spend just another second on this point, is when you are dealing with bruxism, define your strategy. And even if you say, oh, very interesting topic, this airway stuff, it's fascinating, I'd like to get into it, seems like it's a good opportunity for my patients, and it may even add substantial revenue to my bottom line, I'm deciding not to manage that. I just don't feel comfortable doing it. I don't have enough training. I'm busy doing other things. Whatever it is, the reason is, define your strategy, and as you have your strategy, just add to it, if you haven't already done that, the possibility that for those patients that you do keep, know that there's a chance, and usually a good one, that there's an airway issue. Okay? And in those cases, protect the teeth and refer them out. So maybe add to your strategy the referring out in the presence of your bruxism management, and you're successful at that. Say, listen, you might say, for example, to a patient, a lot of patients that have the tooth damage that you have also have sleep apnea, and I've protected your enamel. And I would encourage you to make an appointment with your local sleep lab, and you may even have a flyer to a lab in your area, and encourage your patients to seek help in that area, because I can tell you without question, damaged teeth is a great sign of an airway issue. If, on the other hand, you say, geez, this is an emerging field in dentistry, and I do want to manage the airway, maybe not today, but down the road, there are things you can do today that can help you stick with your bruxism strategy and work your way over time into managing the airway. And we're going to talk about that at the very end, which is taking a measurement. And even if you decide not to fabricate or treat patients with the sleep apnea guard, if you know that that's an issue, then you can be more assertive in getting that patient help where they can get help at a sleep lab. If you decide that, okay, this is something I'd like to take on, I am going to take it on, then you can transition yourself into testing your patient when the test is positive for the airway as prescribed by a physician. Then you can get that patient right back and fabricate the appliance. But at the end of the day, just what I'm encouraging you to do with this slide is further define your strategy. Okay, here's an example of somebody with fairly damaged teeth. This patient had wear and anterior chipped teeth and wear. They had both issues. And the dentist that took this study was at their wit's end with the patient, had done a lot of warranty work on crowns and bridges, and was at their wit's end, was completely unsuccessful treating this patient's damaged teeth. We came into the picture. This was one of the first studies that he did with the monitor that I'll talk about at the end. And lo and behold, this patient was a severe apneic, and that's why their teeth was damaged. So the analogy that I used is if you have a car and you're constantly replacing the tires because they're out of alignment, it really doesn't matter what kind of tire you put on that car. If they're out of alignment, nothing you can do will preserve the tire until you fix the alignment. So in this case, instead of alignment, it's sleep apnea. Okay. All right. So let's talk about if you want to triage your patient, even if if you decide not to tackle bruxism, and it's just good to know what you're dealing with. Okay, because again, like the previous patient, if you fabricate a bruxism guard and that patient spits it out a week later and is non-compliant, says, I hate that thing, why would they hate it? That's a question you say, what was the problem? And they'll say, well, I spit it out in the morning, or I don't like it, or it's uncomfortable, or there's a variety of reasons. In my mind, if somebody can't wear a bruxism guard, that's a checkbox to the possibility of an airway issue. Okay. Now that doesn't mean that if they can wear it, they don't have an airway issue. It's just the negative outcome is a sign that I implied that a guard can make the apnea worse if they have it and no one knows it. And when you make the apnea worse, it's just very uncomfortable for them. So take a measurement. They're easy. There's a test. Here's the report. If their AHI is anything above 5, then you have an airway issue. There's a lot in this topic. It's out of the scope of this webinar, but know that if it's very simple. If that number is above a certain amount, then you can protect the teeth and refer them out. If you decide to take on the airway, then you know that we have to get a physician involved and so on and so forth. Okay. In the case where your strategy is, I do feel comfortable fabricating sleep apnea appliances. Most people that have taken any type of coursework in this know that the physician must diagnose the patient before you can treat them. This is, if you've ever heard of people getting excited about dentists doing this, this is why they get excited about it. Not excited, or have concerns about dentists in this area, is because they don't want dentists practicing medicine. Okay, this is the case where the physician does the medical work and you do the dental work, which is fabricating the appliance. And that's a very simple thing for us to do. Okay, so let's talk about basic questions on appliances. When you're talking to a patient, okay, and this will kind of go towards appliance selection. In fact, this is directly related to selecting the appliances. Notice I haven't talked much about appliances yet because I'm a firm believer in we really got to hone in on what exactly we're dealing with. Okay, so when you wake up, do you have jaw discomfort? And then it goes away as the day progresses, or vice versa. Do you wake up fine and then as the day goes on, your jaw pain gets worse? In the presence of damaged teeth, we're pretty clear on what that means. I mean, so if you wake up with jaw pain, that probably means that while you're sleeping, you're clenching and grinding. Okay, why is that? If it's bullet 2, if you're fine and then as the day goes on, you have jaw pain, then you have some type of behavioral issue where you just would focus more on behavioral changes rather than anything else. Has anybody commented that they hear you grinding your teeth? Do you snore? Most people know if they snore or not. What'll happen is they won't think they snore, but that's their bed partner. If they have one. Does your bed partner snore? I don't think so. Oh, yeah, they do. And I can tell you with teeth grinding and snoring, there's a tremendous amount of denial, and it's not necessarily dentists patients in a dental chair are just kind of lying to you. It's the problem occurs while they sleep, so how would they know unless somebody tells them? So on bullets 3 and 4, it's always good to bring the bed partner in on those questions because they would know better than the patient. Based on tooth damage, ask the patient if they're aware of bruxism. And you guys know better than I do. When you talk to a patient, you say, geez, look at all this damaged teeth. Do you clench or grind? No, I don't clench my teeth. I don't know why they're damaged, but it's not from that. Or they'll say, oh, I played football as a kid, or whatever. And you'll say, well, football doesn't cause wear on your posterior teeth. So maybe there's something else besides a football injury going on here. Okay. So based on these questions, align your treatment strategy on what you're going to do. And then again, are you going to tackle bruxism in that broad category and then refer out if you suspect or learn that they have an airway issue? Or are you going to incorporate managing the airway into your practice? All right. Visual inspection. You guys could teach me this. I think the main thing here is that there's a whole category of malocclusion that's related to tooth damage. We're not going to talk about that today, but you know what you're looking for when you're going to treat a patient and you're looking at their teeth. Okay, so let's talk about guards, bruxism guards. There's a number of strategies here. There's pain relief. There's do you believe in soft appliances or hard appliances? I think the more popular category right now is hard appliances. Soft appliances have pros, but they probably have more cons than pros, from the popular consensus. Based on the airway that I've talked about, just take into account, am I going to crowd the tongue? Okay, so if I suspect my patient might have an airway issue and I'm not going to take that on, I'm going to make them a guard and refer them out, just know that the tongue needs more space than probably the average person that doesn't have an airway issue. So when you're making a guard, take into account, say, they're tired, they snore, but they have a lot of damage on their teeth. I'm gonna prevent further damage and refer them out. Whatever guard you select in that particular scenario, allow room for the tongue. Okay. Do you believe the bruxism is some type of function of a patient not in centric relation? And are you going to reposition or help them relax the jaw into centric relation? Are you going to mitigate the strength of bruxism by an NTI type device? And the strategy there is to disengage the trigeminal nerve and the parafunctional EMG activity that's occurring, and therefore it dramatically reduces the strength involved in the activity, and it helps people, quote unquote, kind of break the habit of teeth grinding. So if there's some type of behavioral component, or you want to get the patient to relax their muscle for a period of time, there's obviously you have to worry about the side effects of such a small appliance. And obviously there's the risks of super eruption and things of that nature, which is kind of what number 5 is talking about. Is this a short term or a long term? The long term, I have to say that there's a lot of hopelessness tied to treating patients with bruxism. And I don't know, we're making progress in triaging patients that can be helped. And so there is a large population of patients with bruxism that we can eliminate or greatly reduce bruxism. So there's not, the long-term bruxism treatment comes in the form of triaging the patient and sorting out those patients that can be helped, and bruxism can be reduced or eliminated. Or are you going to deprogram? There's an interesting topic that I learned from a friend of mine. He called it rhythm pattern generation. And that has to do with patients that, for one reason or another, have a period of time in their life where they have stress over time. And tied to that stress is kind of your gnashing, while you're awake. And what happens is your masseter group, or your muscle group, your airway muscle group, just kind of learns that this is what you do, and then when the stress is relieved or reduced, you continue that behavior, even though the thing that started the behavior has passed. So now you're kind of in this habit of clenching and grinding, and you don't, and you say, I don't have any stress, but maybe 3 years ago you went through a divorce or something. So deprogramming and dealing with rhythm pattern generation is definitely a Bruxism strategy that I encourage. I'm not going to spend time talking about the pros or the features and benefits of Bruxism guards. To be honest, it's not a strength of mine, and I believe the people on this call could probably teach me a lot more about that particular topic than I could teach you. So just know that as you're approaching these are the ideas that I have on that area. Okay, so we're going to shift gears a little bit. I'm going to take a pause here and see if there's any question. It doesn't look like there is. Okay, so we're going to talk about sleep apnea, the upper airway resistance, and snoring. I already mentioned sleep apnea is a medical condition. Snoring is not. You can't get paid for treating sleep apnea through dental insurance. Most people know that. Snoring, no one pays for snoring except for patients, which is probably good because the one thing that patients are willing to pay for is help in snoring. It's the thing they perceive as a problem. If you don't know that you have sleep apnea and you don't perceive any type of problem and you do a test on that patient and they have an AHI of 35, which is very high, and you say, okay, I'm going to treat you for $4,000, they're going to say, forget it. I'm not paying that. I don't even have a problem. So that's that's an issue that you have to deal with. Snoring, not so much. People know. They either know they snore or their spouse has told them they snore, and now that snoring is causing a problem. So there's a perceived problem. And then I talked about upper airway resistance. Okay, so these are when I talk about airway issues, these are the 3 issues that I talk about. Okay, and I don't call it sleep apnea because snoring is not sleep apnea, and upper airway resistance is not sleep apnea. Okay. Sleep apnea is just the first one. All right, so I divide sleep apnea guards into 4 categories, and I call them class appliances. There's the twin block, which is probably, it's not commonly used for sleep apnea, but it is. I mean, dentists are kind of a lot of dentists are faced with these situations where there's no funds available, and this one of the things that you can do in an inexpensive way is twin block. Take an impression, have the patient go protrusive, bite into a tray, and then make them a guard. And people do that. You can't get paid for medical insurance, but it's done. So I talk about twin blocks, and now there's a series of quote unquote twin block guards out there, and we'll talk about them. There's dorsal fins, probably up there the most common, one of the more common, probably number 1 or 2 type or class of appliance out there. We'll talk about a variety of those types of appliances. The strategy on the dorsal fin is that as you bring the mandible and the maxillary together, there's the ramp that causes the mandible to protrude. So as you close the gap, you're sliding the mandible forward, and you can see the mechanism there that adjusts that amount of protrusive therapy that you can offer using a dorsal fin. We'll talk about a couple of dorsal fins. Dual hinge. If somebody said, guess what's the most commonly used type of appliance, I would say it's dorsal fin. Of all the appliances, I know it sounds silly, but they're the least attractive. And you might say, well, who cares? But when you're showing a patient, a $3,500 item or whatever it is, I just pick these numbers out, and you show them a contraption, it has an impact. Just know. So, but dual hinge, we'll talk about those, and then the last kind is the anterior hinge. And actually, the first FDA cleared appliance, the silencer, was created by Dr. Hallstrom up in Canada. And Dr. Hallstrom had an orthopedic appliance and found that he, just by happenstance, that the patient that he had been treating reported that they felt better somehow. And he developed an adjustable interior hinge, the silencer. That was 25, 30 years ago. So we'll talk about interior hinges. There's a lot of those types of guards out there, or sleep appliances out there. Okay, so let's talk about twin blocks for a little bit. Twin blocks, just taking into account, they've been around for a while. They offer a lot of lingual space because there's nothing interior, usually. They're generally not adjustable. So the medical insurance requirement is not met, but the dentists that use twin blocks are not typically billing insurance, okay? And the twin blocks, we all know, weren't designed or created for this particular purpose, managing the airway, but it does get used from time to time, so I thought I would mention it. One of the negative aspects to twin block is that it does lock the mandible in a fixed position. And if you decide to take a measurement on a patient, we'll talk about that at the end. What happens is if a person's used to, if they're a grinder, for example, and their bruxism energy is lateral or front to back, then when you lock that in place, that's just another function or another aspect of therapy that they have to get used to that will probably cause some discomfort. An upside is they're inexpensive. Generally, twin blocks are made chairside. If you send them out, even so, they're still on the scale of lab fees. On my presentation, I was going to put dollar signs on this, but I kind of decided against that. But know that the twin blocks are probably one of the least expensive of the appliances to make. And again, twin blocks aren't commonly used to treat sleep apnea. Let's talk about dorsal fins. Obviously, dorsal fins are adjustable. They can be difficult for patients to place. So just the nature of them is depending on the type of dorsal fin, you have to open wide. And people with limited mandibular motion or people that have a sensitive gag response, those folks find these types of appliances a little difficult at first. And when you're dealing with any known challenge on an appliance, like let's say that you use a Somnodent, great appliance, I like it a lot. I hear nothing but good things about the Somnodent appliance. As far as the quality of the appliance and its adjustability and its attractiveness and comfort. The downside again is that it's a fairly large appliance. So if you know that and you tell the patient, okay, we're going to get you a Somnodent. I've had a lot of good success with it. Patients like it. It's a little large. When you first wear it, the first couple of nights, you're going to be sore and it might be a little difficult to place. Work through that, and say, listen, if you place it and it's uncomfortable, wear it for as long as you can and then take it out. And then the next night, have a goal of wearing it longer and build up the tolerance to it. And then over time, if everything goes well, the patient can get used to it, okay? I do mention on this one, obviously, that all dorsal fins are adjustable, and their adjustment mechanisms are generally the same, with the exception of the microdental, the O2. That's a fairly new one. That's the picture on the left on this one. And what the dorsal fin folks do is when you order an appliance through the lab, you get a set of mandibular trays and the fin is in various positions. So you might start in one position, get the patient, 60%, 70% protrusive, call them in a week or two, say, yeah, this is fine, I feel a little better. I was sore first, but not quite as sore, it's fine now. Give them the second tray and it will be more protrusive. And then find out, track the side effects, pain in the morning, tooth movement, that type of thing. And obviously in the sleep apnea, you do want to find out where they're at with their disease. So at some point, the patient's going to say, I feel better. The spouse is going to say, Jesus, great, he doesn't snore. Do another home sleep study. Find out. So if your AHI, for example, was 25 and you're in the middle tray, so you have your mandibular tray, you get 4, let's say you're on the 3rd one, the patient feels better, the spouse reports no snoring, and their AHI was 25, you do another study and it's 10, then decide, do you want to go to that last tray? And the reason that I say take that decision carefully into account is because obviously the more protrusive you go, the more strain you're putting on the system, and the more likely you are to incur or have to deal with side effects, jaw pain, clicking, tooth movement. And so you want to make sure that you treat the patient and with the least amount of protrusive adjustment that you can without not treating them, but you don't want to kind of over-treat them. It's like if you were to equate this to CPAP, what we used to do is kind of turn this dial till they were breathing normal, and as techs, we were tasked with the responsibility of not turning that dial too high. So we didn't, if somebody needed a pressure of 10 on CPAP, we didn't want to recommend 12 or 13 or 15 because then 15, CPAP pressure of 15 is much harder for a patient to deal with than a CPAP pressure of 10. If 10 will do it, then 10's the pressure. Same thing here. If your protrusive amount is 80%, why would you want to do 90% if they're treated at 80 when you're going to incur more side effects at 90% protrusive? Same thing like with the CPAP pressure of 15. So when you're titrating using dorsal fin and you're adjusting, the key task here is to weigh where their therapy effectiveness is against the increasing risk of side effects the more protrusive you go. Okay, and that's with any appliance. Okay. The microdental O2, that's a small appliance, so if you like dorsal fins but you find that the Somnodent tends to be a little bit large, you might try that one. The other dorsal fin that well, it's not really related to dorsal fin, but with any appliance, if you have a lab that does good work for you and you call them, you say, do you have appliance? What sleep apnea appliances do you recommend? They might say, oh, we have, there's an appliance called the dorsal fin appliance. Okay, so okay, I'm going to send you an impression for a dorsal fin appliance. Here's the protrusive measurement. Here's our kind of starting point. And then get familiar with how that particular dorsal fin appliance adjusts, and then go for it. Make one. Even if it's your first one, just go for it. After you've gotten your training and you feel comfortable and you have a patient that's an appropriate appliance for. Okay. Next appliance type. It's the dual hinge. There's a whole bunch of them. There's probably more of the dual hinge appliances out there than any other type of appliance, if I had to guess. And they again, the idea of the dorsal fin and the dual hinge, actually almost all appliances, we're wanting to push or pull the mandible out. So depending on the type of appliance, the difference is, are you pushing the mandible out, or are you pulling it out? So that's the fundamental difference. At the end of the day, where is the pressure being exerted as you go protrusive? Okay, so as you're taking this into account in your patient, maybe they have some, there's been some, there's missing teeth or what have you. Depending on where that pressure is exerted to will dictate what appliance you select. Okay, so just kind of take that into account. Again, dual hinge. It's a customized, it's made like almost all these appliances starts with an impression. with dual hinge. There's lateral hinges. The hardware, you can look, the one on the right, that's a Herbst. Herbst is the top one or two, maybe third appliance out there. A lot of people are benefiting from the Herbst. There is, if I had to say, I don't want to say a negative, but be sure you take into account that hardware on the side is pushing against the cheek. Okay, so just know that. So I don't say that as a negative. I say that as when you talk to your patient, you might give them a heads up saying, listen, it might take you a little while to get used to the Herbst. Look for pressure on the side of your cheeks. If you feel that, give me a call. We'll figure something out. You'll notice with the Herbst on the right, there's bands. There's a band on each side, a rubber band. That's to help reduce the chances of mouth breathing. So that's an option on these appliances. So on the Herbst, there's little posts that they put in the hardware that will allow you to put a band, and the idea there would be that you pull the mandible closed. I find that there's no piece of rubber on earth that could keep a mouth breather from opening their jaw. But in the relaxed condition while asleep, if we just need a little bit of upward pressure to keep the mouth closed, then great, go for it. The other part of this that you have to take into account if you're going to look at mouth breathing is just because the mandible's closed, obviously your lips can open. And so you just have to remember that even if you get the bands, you might not end up managing mouth breathing because of the fact that what I just mentioned. The middle appliance there with the yellow bands, that's the EMA. The EMA is a fairly small appliance. It's those bands. The adjustment is the band. So as you, and this one is pulling the mandible forward. Okay, if you look at the Herbst pushes the mandible forward. Okay, so on this one, if you don't have any front teeth, the EMA is not for you, because you're going to be put. Most of the pressure is going to be pulled a little bit more towards the anterior teeth than the posterior teeth. So just kind of take that into account. The Herbst, you can see that the pressure is going to be exerted on the posterior teeth. So the opposite is true on that one. The idea there is if you have missing teeth, take that into account. The other probably the probably more important factor between the Herbst and the EMA is cost and durability. You're going to save some money on the lab fee on the EMA, the middle one. The Herbst, there's a range for the Herbst lab. There's a range on all these, and so I'll try to do my best job to kind of estimate the range on the lab fee. $325, $350, $400, and again, that's not one lab being less expensive than the other. I think the biggest factor in the price variability is what options do you order with your Herbst. On the Herbst on the right, you can reinforce the teeth if your patient is bruxing. Okay, so you can get that wire mesh embedded in the acrylic, and you can see that there's the wire mesh on the side, interior and exterior rails of the appliance to help provide support to patients that clench or grind. Okay, the EMA, you're going to save money. However, the durability, what you lose is durability. Okay, so a lot of times, if you don't have if you don't have a substantial budget, or you have budget constraints rather, the EMA might be a good option. And just prepare your patient. Say, yeah, the EMA, I like it. It works well. And I have no evidence that you clench or grind, so great, but know that we saved you quite a bit of money, and it's not quite as durable as some of the other options that we have. And if you prepare the patient in a very kind of not professional way, but you just are upfront with them. Say, listen, we're going to save some money, but it may not last as long. If you want to spend more money and have the assurance that it's going to last longer, then we have this other option. Sometimes you don't want to give your patient those options. You just give them the EMA or give them the Herbst. It just depends on your strategy. So some dental offices will say, I have a $2,500 track and the EMA is on that one, and then you have the $3,500 track and the Herbst is on that one. That might be an example if you do offer options, how you manage that. The last dual hinge that I'm going to talk about on this slide is the Narval from ResMed. ResMed is the #1 CPAP manufacturer. And they, several years ago, bought a company that had a novel approach to this. I believe it was the first, they hate that I use the word, but just so I can communicate how it's manufactured, they mill it from a block of nylon. And it's actually here in California. So if you order a Narval through Great Lakes or Smiles or what have you, it all goes to one lab here in Hawthorne, California. And they have this very sophisticated array of lasers that take your impression. They scan your impression, so you don't have to scan your patient's teeth and send in a scan. You take an impression, send it into the dental lab. The dental lab sends it to the actual laser facility in Hawthorne, and that facility has a very sophisticated scanning technique, and they convert your impression into a scan. I know that it's very popular now to buy a scanner and skip the impression step. That's not what they do here. So what happens is they will take a couple of blocks of nylon, and 8 hours later you have your appliance. It's very small. It's very comfortable. It is also very expensive and very difficult to adjust. So when you go to fit it, because of the material, it's not acrylic, it's nylon. If it's too tight, you're in luck. You can get your little Dremel out and make it fit. If it's too loose, there are some things you can do, but you can't add material to this nylon. So I would say if there's a thing to consider about the Narval, its upside is it's comfortable. It actually looks very cool. I mean, if you look at the Herbst on the right, and you look at the Narval on the left, if we're in a beauty contest, I think the Narval would win. The adjustment mechanism is kind of hard to see in that picture, but there's nylon posts, and again, they're going to pull. There's no anterior support, so you need to have all your posterior teeth, or nearly all your posterior teeth, on the Narval. The reason for that is they wanted to give the maximum amount of lingual space. Okay, so they basically just have a very thin band that connects the two sides. And so, if you have a patient that has 3 missing posterior teeth, they're probably a better candidate for a Herbst. If you have a patient that has a huge tongue and they have all their teeth, the Narval is probably a better option, for example. There's the budget. On average, the Narval lab fee hovers around $500, so it's not a small investment. And depending on what your multiple is when you on lab fees, that could boost up the price you have to charge your patient by a pretty good amount. Okay, so the Narval, great appliance, I like a lot. The reason that I like the Narval is that nylon material that they mill it from is very, very strong. So once you get this to work, you probably won't have to replace it. That's why they have this crazy 5-year guarantee, because they know it's not going to break. What they have to do is get a good impression and make it fit. And if we achieve that, and the dentist does a good job of titrating, we're done. Okay, unless the patient has tooth movement. We're going to talk about that in a little bit. So that's dual hinge. All right, so I'm going to pause again here and see if there, it doesn't look like we have any questions. Okay. Um, all right, so we're going to talk about anterior hinge next. The silencer that I mentioned earlier, that was an anterior hinge. And you know, again, they're all adjustable. I probably shouldn't have, I should have just said all sleep apnea appliances need to be adjustable. Um, the anterior hinge, when the silencer was created 25 or 30 years ago, we didn't have the understanding that we have now on the role that the tongue plays in compromising the airway. It's not the only thing to take into account. I think the people that there's a category of dentists that say, oh, you have to have a ton of lingual space, otherwise your patient's apnea is going to get worse. Well, that might be true, but it might not be true. Sometimes the tongue has nothing to do with the airway problem. The airway problem can occur in a variety of locations, the tongue being one of them. And the tongue, don't be fooled. It's a prominent player in this. I'm not trying to minimize it, but it's not the only player. So, and when I say player, factors that contribute to an airway issue. So you can kind of guess how this adjustment works. You can see that there's a kind of a set screw in the front. And there's a little hook mechanism, and that hook mechanism gets pulls the mandible forward as you adjust the set screw. So that's the silencer. The TAP Elite 3 is probably the #1 anterior hinge out there. And the TAP Elite 3 uses the herps, I'm sorry, not the herps. The silencer has a pin in a box mechanism, and when you adjust it, that pin gets pushed, causes anterior movement, or causes the patient to become more protrusive. With the TAP Elite 3 and the TAPs and the TAP Elites and the MyTap, and there's a variety of taps out there. They generally have some type of hooking mechanism that's engaged with a bar. And the reason that they're engaged in a bar, and I like this, is it allows for a lot of mandibular movement. So I forgot to mention on the dual hinge. The dual hinge, one of the major upsides to that is it allows for a tremendous amount of mandibular movement. And the reason that you should care about that is it's easier for patients to get acclimated if they can move their mandible. And the way that the anterior hinge appliances provide that feature is they have some type of post or hook mechanism in a way that doesn't lock the mandible, but it allows for typically a little bit of vertical movement and a little bit of lateral movement. And the silencer, not so much. I mean, there's a little bit there, but it's kind of in a box, and it allows for maybe a little bit of a millimeter or two of lateral movement. But at the end of the day, as long as a patient can move their mandible, you get the advantage of it being a little bit easier to get used to. So that's what I would say about that. Okay, so lab piece. This one's right in the middle of the road. It's not high. It's not the highest range. It could be. The silencer, I have to say, is probably in the high range. I probably misspoke. The reason the silencer is probably a little pricier than other appliances is that the materials that they use in their manufacturing technique, because it was the first apnea appliances, they used the techniques that were available at that point in time. And that's fairly expensive, their manufacturing techniques. But it's a very strong appliance, and it's still, even 25, 30 years later, with all that's gone on in dental sleep medicine, is still a big player in the appliance world. Okay, and we all kind of owe a little bit of debt of gratitude to Dr. Hallstrom. Oh, I'm sorry, guys, because they tend to. Dr. Hallstrom's the one that started this whole thing. Okay. All right. So kind of in review, I kind of wanted to sum up, the sleep appliances. I know we're going to go a little bit over today, but not much over because I'm almost done. when you're taking into account the sleep appliances, we've talked about a lot of things. I can tell you that dentists on the low end charge $600, on the high end about $4,000. You'll hear stories of dentists going even higher than $4,000. My goal isn't to brag about how much I got paid to do an appliance. My goal is to prepare you for the range of fees that can be charged. The 600 is usually a fee for service, and typically it's to manage snoring. The 4,000 and up is almost always the medical insurance participates in reimbursement. It's rare that a fee for service is above 4,000. It's there, they're out there, but it's rare. Another thing to take into account is anytime you're dealing with a chronic condition, sleep apnea and snoring are a chronic condition, you have to take into account that there's a compliance issue. It's the nature of any chronic condition: heart failure, high blood pressure, you name it, cholesterol, asthma, the list goes on. Anytime you have a chronic condition, therapy is challenging. Okay, so you have to watch your patient carefully. And in the case of sleep apnea appliances, there's certain things you should target when you're watching your patient after you've implemented therapy. The easy one is jaw pain and discomfort. Is it intolerable? Do you have to back off on the protrusive? Manage that. The next one is tooth movement. Okay, you need to prepare your patient for the fact that I use the term likely. There will likely be tooth movement where you can't help it. You're putting pressure on teeth, and they're almost in kind of an orthopedic guard, and then you're pulling or pushing on it. There's going to be tooth movement. So what I recommend is that you prepare your patient for what they'll feel when tooth movement starts to occur. Do you feel that your posterior teeth aren't coming together? Do you, any subtle change? When you go to eat a salad, can you not chew on the lettuce? Or whatever it might be, just prepare your patient. Say, listen, it's not unusual to have tooth movement. Here's what you need to look for. And then as soon as you detect or feel or sense that you have any one of these, give me a call and we'll figure out what we want to do about it depending on what you notice. Okay, so just prepare your patient for it. The thing that you want to avoid is surprise problems. If you don't say anything and then they say, geez, my back teeth aren't working, I'm not going to wear this anymore, they may not even call you. They might just say, oh, this is ruining my teeth, I'm not going to wear it anymore. Okay, so prepare them for it. And then if there are strategies that you can use on each of the, jaw pain, we'll talk about that strategy in a second. Tooth movement, I just mentioned that, okay? Morning repositioners. So this has to do with relieving the stress that the masseter has been on all night and help put the teeth back in place. So this positioners kind of address both the top two side effects of oral appliance therapy. It gets the jaw to relax in the morning, and it gets your teeth to kind of resettle into this where they should be. You wear them for some minutes in the morning. A lot of times you take your appliance out, you put it in some water, clean it, put in your repositioner, take a shower, get cleaned up, take the repositioner out, and you're done. If you don't want to go down the repositioner route for one reason or another, have a strategy. Chew a couple sticks of gum in the morning. It could be that simple. It could be you give them a handful of tongue depressors or whatever. Just do something. Just do something to alleviate the pressure, because when you're 85% protrusive for 8 hours, that's like doing push-ups all night. In the morning, if you do push-ups all night, your biceps and chest are going to be sore. And so you would want to do something. The same thing here. So that's the idea of a repositioner. I encourage you to do it, but the reality is there's a cost associated with this, and sometimes it's not in the budget. If it's not in the budget, come up with a more creative solution, but emphasize the importance of it. Chew, if your strategy is chewing gum, okay, say, listen, it's really important that you do this. If you don't, your teeth are going to move and it's going to be less comfortable for you. Okay, be a little assertive with your strategy on managing the side effects. Okay, I am way over, so I'm going to speed up. The BRX Pro. Going back to appliances and actually any long-term treating any chronic condition, sleep apnea being one of them. One of the pain points from a patient's perspective is if there's interruptions in the process. So let's say that you've done a home sleep study or your patient's been referred to you from a sleep lab for fitting for an oral appliance in either scenario. You say, okay, I'm going to take an impression and come back in a month when I get your appliance from the dental lab. And you call the patient in a month and they're not taking your call. So you have this appliance that you can't fit. Okay, not unusual. Or let's say that you've done a home sleep study. You get the letter back from the physician who's interpreted your study, and it says fit them for an oral appliance. You go to call them because it's 3 weeks later. They say, "Oh, I'm much better now. I don't need an appliance." Okay. Same thing with CPAP. You go to a sleep lab, 6 weeks later, somebody from a DME calls and says, I'm ready to do your CPAP. And the patient's going to say, I don't need CPAP anymore. Or they'll take their CPAP and 2 days later, they put it in the closet and never use it again. Okay, you have to keep the patient engaged the whole time, and that has to do with any therapy, any therapy of any chronic condition. CPAP, again, sleep apnea being one of them. The BRX Pro, transitional to long-term. That is, in the morning, if you did your home sleep study, say, wear this, let's get you used to wearing an appliance. If you've received a referral, take an impression for your sleep apnea appliance, send it off to the lab, give them a BRX Pro. Again, I'm in sales mode. Sorry, I didn't mention that. Whitmix sells the BRX Pro. Get them into a BRX Pro. They're very inexpensive. They're less than $90, and get them wearing the BRX Pro for the few weeks that you're waiting for for your long-term appliance to come back. The BRX Pro has it's a couple of impression trays, and so you have some the NTI concept where you prevent the posterior teeth from coming into contact with each other. So the BRX Pro is 2 partial arches. Okay, it's only used for a couple of weeks, so don't worry about super eruption. It's not a long-term appliance. A lot of people ask, oh, what about super eruption? Don't worry about it. If you're worried about it, the super eruption, you're using it for too long. Okay, it's adjustable. There's 4 positions, so you can move the mandible out a little bit while they're waiting for your long-term appliance. It protects the teeth. Because again, if you improve the airway, and the BRX Pro has been shown to improve the airway, if their airway is triggering parafunctional activity, you improve the airway, there's less parafunctional activity. Okay, and it keeps, most importantly, it keeps the patient engaged. Okay, and then you can also establish, okay, if they're going to, if you suspect that this may not work, try the BRX Pro before you do your impression for the long term and see, can they tolerate the BRX Pro? If they can, and say, come in, let's take an impression, keep wearing the Pro, and then when your long-term appliance comes back, we're going to trade. Okay, that way you save the outcome. Imagine this outcome. You take an impression, you got your patient, either your physician's diagnosed them or you received them from a sleep lab, you take an impression and you order an Narval. You pay $500 for an Narval appliance. You have it in your hand. You call your patient. They say, I'm not wearing that. So now somebody's on the hook for the lab fee. Okay. All right. I'm going to skip these. If you're really interested, again, this presentation is in the handouts. Feel free to download it. I've gone too long. Sorry, guys. So this is all about the BRX Pro and kind of documenting that it works on improving the airway and the parafunctional activity. And it even helps with snoring. Last thing, 2 recommendations for you. Dawson Academy has a kind of a whole health wellness line of courses that Dr. DeWitt Wilkerson offers, and it's just a fantastic course. I encourage you to call that number, that 800-952-2178. Find out when the next course is. He does a fantastic job. I've been to a lot of these courses, like a lot of us have, and he does a great, thorough job of integrating overall health, and sleep being an integral part of overall health. Another recommendation, this is a little bit different style, that's why I mention it. Dr. Haley is a dentist who is making 50 or 60 sleep apnea appliances a month. Billing medical insurance, tremendously successful, does a great job, and she shares her kind of where the rubber meets the road. She plowed through all these issues one by one: medical insurance, symptoms, what's the best appliance, sleep apnea, the medical condition, the physician part, on and on and on. And for these modest fees, she will show you how she did it, okay? And we know it works. She's been very successful. Again, her number is 912-638-3559. Okay, great. And you can just pick the topic. That's what's great about it. You just pick the topic that you want to learn about. Last thing, or two last things. One, don't forget, if you want to do the 1 hour CE credit, take the test, download it. Alternatively, you can email me and say, can you email me the test so I can get my 1 hour credit? I will be very happy to do that. On the monitor, if you want to start to get testing your own patients, even if you want to just assess the bruxism and refer out the patients that you've learned are apnea and not bruxers, just shoot me an email. Say, I want to learn more about that monitor and testing, or I'm in, I'd like a quote, whatever the case is. By all means, just shoot an email to me. My email is jeff@ddmeonline.com. I should have had that on there, sorry. Or you can just reply to the email invitations that you received to go to this webinar. So again, thank you. If you want to hang out for a minute or two, at 10:15, and as soon as I see everyone leave, except who wants to stay, by all means, stay, and I just have a couple of questions I want to ask you guys. So again, thank you, and have a great weekend.